thank you very much for the invitation. It's a pleasure to be in this joint meeting. I'll try to speak about our experience in the minimally invasive neurosurgery. So, as Howard has said, the most important person in the operating room is the patient, as already mentioned. So we have tricks, we know things to do, but we have to ask ourselves, is what I'm going to do is better for the patient? It will serve for his best. So what's a minimally invasive surgical procedure? Is a procedure which is safe and which has a lower postoperative patient morbidity. If we cannot do it in less time, in less costly, or it's not safer, it's better not do it at all. And why we are now able to have this minimally invasive surgery, neurosurgery, because we have better instruments and we have a better industry. And we have also to know that these procedures have a learning curve. So we are not best at our first attempts, but we have to learn to be better and better after each procedure. You don't do this procedure because you know how to do it, but you have to be sure it's safer for the patient. And during our work, we have to produce facts that these procedures are equal or better in results as the conventional procedures, can be done with less trauma, are less risky for our patient, and maybe has a cost reduction. So I reviewed some of my latest cases, and the first one I wanted to show is this hypertensive hematoma in a 55-year-old lady. Who came with a left hemiplegia and a volume of 50 cc and a Glasgow Coma scale of 15. After 12 hours of conservative treatment, she became Glasgow Coma 6, and the hematoma had progressed. So I made a small craniotomy 2 by 2, and I managed to evacuate the okay. I don't know what's happening with my video. Sorry. Okay. So I managed to reduce the volume by 90% and to make sure that she didn't die from that brain hemorrhage. And this by a very small craniotomy, so very small cortical incision, and no surgeon-induced damages. The second one is this clear multilocular abscess in a 44-year-old female which is being treated for multiple sclerosis for some years, and suddenly she developed headache and lethargy. So we have this abscess, multiloculated, and the first thought is to have a grave craniotomy, frontal, to try to have this evacuation. Maybe if I go here, I might have a possibility to have all the cavities drained one by another, which is going to perform just a very, very small craniotomy, which I did. I'm showing the bar hole using a microscope. I managed to evacuate this is the immediate postoperative MRI, where there is some residual pus only in the bottom, and after medical treatment also, we have this maybe 6 months follow-up MRI showing only the sequela of the abscess, but no surgeon-induced sequelas. Trigeminal neuralgia, it's a well-known disease and have many possibilities of treatment, beginning with the medical ones. But when you have a patient who is refractory to the treatments, you might offer them the decompression. And I tried this endoscopically. It works. It's this is my first procedure. I had the endoscope in my left hand, and the free hand without holding devices. I'm trying to open the cisterns to have some CSF evacuated. And here is the fifth nerve and the vestibular here, opening the arachnoid. The downward vein, which is left intact. We're using some instruments not especially devised for this kind of surgery, but nevertheless, they work. Here is the arterial loop, which was evident in the MRI, but also this vein, which is just in the dorsal root entry zone, and which is probably this one responsible for the vascular conflict. So I'm trying to dissect and to make possible these structures are apart from each other, and I'm not able to move fast forward. And this is the incision, a very small incision, just 1 week after the intervention. And she experienced the same relief as the others experienced from the conventional surgery. So it's a procedure with less trauma for the patient and equal results as the conventional one. This might not be the classical example of a minimally invasive neurosurgery, but to be able to remove a tuberculum cella meningioma through the nose, I think that you put your patient in less risks than in the conventional one during craniotomy. If the anatomy of the tumor allows. So he came to us with this visual defect. To perform this kind of surgery, you need a good ENT surgeon, which luckily we have, is Dr. Aga. So endonasally, the flap for the construction, anterior fossa, some neuronavigation just to be sure what we're looking at. with drilling of the anterior fossa, carotids, optic. This kind of interventions converts cranial base meningioma to a convexity meningioma, because you approach it from the point of attachment. So you devascularize, and you have the opportunity to remove this nasal component of the tumor, which is not possible from the intracranial route. So we are opening the dura. And now we're looking at a tumor which goes very hard. We're trying to make some kind of debulking, but in fact we're using those cutting devices for the bone of the septum. You can see the nevertheless, slowly we tried CUSA, but same thing, a very little possibility to debulk. So finally we arrive at the arachnoid plane, and we preserve it, which enables us to remove piece by piece and to be able to protect the perforators. You will see the optic nerve on the right here. We are lucky enough, the left nodule came out easily. If not, we were prepared to leave it there. You see the left optic a little bit. Now it's better seen. Again, the dissection is very slow and carefully. We know the meningioma has always this arachnoid membrane over it, so if we take care to have that membrane, we are always sure to not do damages. So let's be a little bit of meningioma going out. Now we are taking the infundibulary stalk and the attachment to the diaphragma cella, and we are removing the meningioma from there. A little bit of meningioma in the optic canal on the right, which we're trying to remove. We're opening up the optic canal and removal of that fragment. And finally, it's an inspection on the lateral margin. We thought we saw a little bit of meningioma staying there, the olfactory nerve, both optics, chiasma. And a very important part of this kind of operation is the reconstruction of the anterior base. So we put fascia and then some fat, and after that, the gasket seal technique with the second layer of fascia and the part of nasal cartilage. And to support of all this, we have a nasal septal flap, which was prepared at the beginning. We haven't used any fibrin glue or something sealant, any sealant material. But after the flap, some Surgicel and Posicept and Marocel to put all together, to keep all together. He didn't have any leak, any meningitis, and his vision improved slowly during the follow-up months. His vision was becoming better and better. So I think we did him a good service with the Simpson 1 resection. Another one case of minimally invasive neurosurgery, this dermoid cyst, mesial, large, but if I go supraorbital, I have very little brain to transgress, and then I am in the cavity. So that's what I did. It's an eyebrow basal frontal craniotomy. At the beginning, I tried to remove as much as possible using the microscope, but after removal, it became clear that I wasn't able to remove all the cysts. So I converted to the endoscopy. I can't fast forward the image. So now I'm using the endoscope, also free-handed. I'm trying to enter the corticotomy I have already made. And now I have a much better view, which means I'm much more sure of what I'm doing, which means the patient is safer from my actions. And now you see very clearly the carotid and the A1, and in the upper part of the screen, the optic nerve. And so slowly but safer, I'm trying to remove every part of this dermoid cyst. So this is my patient just 1 week after the intervention. This is the craniotomy and the MRI, which reveals the total removal of the dermoid cyst. So in conclusion, we have to be safer, but less trauma for the patient. And probably this is the future of neurosurgery. And I thank you very much.
Thank you for those very nice pictures and videos. Well, one thing I sometimes I do scrub base as well as time, very little now. But I remember when I started doing endoscopic super 7 Germans, with the few with the endoscopic approach, and I found that we lost more than the one. One in visibility, vision, and control, but we lost the smell and sister leaks, as you know, is a big issue. Do you still do all this with the same approach, or you go carry on also properly sometimes?
Yes.
For this particular case.
Yeah, I mentioned a little bit in the presentation, but you have to be very careful in selecting those cases. If you have smell and you think you can't do total removal, then it's better not go that way. So it's But if you have a patient who says, I don't want my cranium to be opened, so you go this way. You have to be ready to offer the patient the best, which is something you decide together. About the rate of leak, we haven't done so much meningiomas, but craniopharyngiomas we've done, and we had a leak, but it was the hydrocephalus. It was not our cranial base repair the problem, it was the hydrocephalus which we didn't see at the beginning. So valve resolved it.
Arthur, you said correct about that first time. Last report published in DNS, you know, the last report of Carral, all the group, on the large experience, and all the people followed that and said that, okay, we will do that. But at the end, the editorial comment was, don't do that in meningiomas because you will lose passion and you will become like Cushing with transplantation. That was the conclusion of the editorial report. Many people will follow what Carral said in the group of, that have the most experience. But in meningioma, be careful.
You have to be sure to remove all that dural tail, which you can't remove from the nose.
It's the main problem. So when you speak to the patient, you will say that you may die.
Of course, I agree, but I fear that first I would say that 95% I've done this kind of tumor microsurgically, but I have my doubts now, serious doubts, because okay, smell is okay, the possibility of a leak is very dangerous, but for me many times the most important thing is vision. And in the end, I almost always open the optic canal when I do microsurgery. And the problem is I seldom see people opening the optic canal when they do microsurgery. And I seldom see a tumor without entering the optic canal. In the same way it entered in your case.
Yeah.
Right? In your case, the right optic nerve was almost ruined because it had a lot of tumor, was very compressed. It's very difficult to do it with microsurgery. So I think in the future, vision will be the most important factor, more than smell. It's very important. They are the two most aristocratic nerves, not coming from the brainstem. Smell from the encephalon and vision for the side from the encephalon. But it's much more important vision, I think. So I think I'm starting to think that the endoscopic is superior to microsurgery for preserving vision, and this is important.
I think as in AVMs is the same kind of thought. You might have both. You might need both procedures, depending on what's you might operate today via the nose, and in 3 years you have a recurrence on the left side of the optic canal and you go transcranially, and it's not a failure. Thank you.